Hello, everyone. Thank you so much for being here. I am excited about this program, and I'm happy that you're all here. So my name is Jamie Seward. I am Associate Director of Affinity Engagement Programs with the Office of Alumni Relations here at Johns Hopkins. And I'm here with our special guest, Dr. Amit Jain, who is Associate Professor of Orthopedic Surgery and Neurosurgery and the Chief of Minimally Invasive Spine Surgery at Hopkins. Dr. Jain's surgical practice focuses on taking care of adults with degenerative spinal conditions and children with scoliosis. His research focuses on improving outcomes and value in spine surgery. He received a BS in bioengineering with high honors at UC Berkeley. He went to Hopkins for medical school, where he received the prestigious Paul and Daisy Soros Fellowship. And he remained at Hopkins for orthopedic surgery residency, where he received the Miller-Colson Award for Clinical Excellence and the Biank Award for Servant Leadership. He pursued fellowship in spinal surgery at the prestigious Emory Spine Center before returning here to Hopkins as faculty. We are very lucky to have him today. I welcome him. Now, before I turn the program over to Dr. Jain, I encourage you to ask questions in the Zoom Q&A, which is located at the bottom of your screen. Please don't put your questions in the chat. We may lose them. So please put them in the Zoom Q&A. Now, it is my pleasure to turn things over to Dr. Jain. Dr. Jain, welcome.
Thank you, Jamie. And welcome, everybody. Our goal today is to talk about backs in the future. These are my disclosures. No relevant disclosures for this talk, but we do have some research funding from the NIH. I'm a member of various organizations, including the Harm Study Group and AO Spine, and have some consulting agreements. My disclaimer for this talk is that this may contain some surgical video clips. So if you have a light stomach or don't like looking at things that may contain a little bit of blood, I recommend that you maybe watch just the clip notes at the end. So our agenda today is that we'll be giving an overview of back or spinal problems. We'll talk about history of spinal treatment, current state of the art in the field, and then we'll touch on some future directions such as robotics, artificial intelligence, and biologics treatments. So usually we would be in person and be able to discuss these topics, but through Zoom, it's a little harder to do that. But at your home, in the comfort of your home, raise your hand if you have ever experienced back pain in your lifetime, have had some back muscles or spasms, shooting pain, sciatica, cramping in your legs, numbness or tingling, or any of those issues. And it's a pretty common scenario. Almost all of us have had some of these issues. And in fact, you're not the only one. 8 out of 10 Americans have some back problem in their lifetime. And unfortunately, people who have suffered from a back problem generally have a recurrence within 2 years. So it's pretty common for this to occur, and then it's pretty common for it to come back. In fact, it's such a large problem that people miss nearly 150 million days of work a year as a result of chronic low back issues. So pretty significant problem in our country. What causes all this? Well, it's a variety of things. In general, the word back is loosely used to describe the spine. The spine consists of a variety of bones consisting of the cervical bones, the thoracic bones, and lumbar bones. And then between them is the spinal canal, which contains the spinal cord and the nerves. And a combination of these mechanical structures result in some combination of either degeneration or a traumatic event, which can cause pain. The most common causes of back pain are degenerative issues, herniated discs, traumatic conditions, or deformity or scoliosis. And we'll kind of talk about each of these a little bit. So before we can really dig deep, it's important to understand that what the spine is made of. At its core, the spine is basically made up of vertebral bones, which are these bony structures. And then between them are discs or intervertebral discs. Now the discs are special structures that act as shock absorbers. And when they wear out, that can be one source of the problem. It's interesting that discs, like any other joints in the body, degenerate with aging. And in fact, as you get older, you start losing the water content in your back, and then it starts undergoing some chemical changes as well. So you have decreased proteoglycan, increased keratin, but the end result is these biochemical changes and loss of the water content results in these discs to degenerate. In addition to degenerative discs being a source of pain, disc herniations can be a source of pain. So especially if you're a young active person, you can have a herniated disc or a ruptured disc. And that basically means that some of the jelly inside the donut has leaked out and is pushing on the nerves. And this pressure on the nerves generates pain. And as you can imagine, as long as this jelly is pushing on the nerves are irritated, the inflammation essentially results in sciatica or other types of pain. Trauma can certainly be a source of back pain as well. And trauma can result in the facet joints, which are these areas in the back that allow motion to see some stress, and that can cause pain as well. And finally, spinal deformity. So conditions such as scoliosis, where you have a genetic propensity to have a curvature in your spine, or as you get older, the discs degenerate and therefore you develop a curvature in your spine. Either way, these combination of events can result in some pain as well because of mechanical instability. So before we can really look at kind of the modern treatment for back pain, it's important to look at history of back pain. So it's gone through a fairly extensive evolution. History dates back to 3000 BC with the text Srimad Bhagavad Mahapuranam, where Lord Krishna describes treating a woman with back pain through a chin traction method. Kind of fast forwarding about 1,000 years, we are at 400 BC, where Hippocrates describes the Scandinam method, where he essentially ties patients, both their torso as well as their legs, and pulls them in each direction in order to decompress the spine and try to get rid of some of the issues that may be pinching on the nerves. Fast forward another 100 years or so, and we get to 30 AD, where in the Gospel of Luke, Jesus heals a woman with sankupyo, which literally translates to bent forward. So this woman had a spinal deformity that Christ heals. And fast forward another 2 millennia, and we are at 1741, when a French physician, Nicolas André, writes a book about treatment of back pain and scoliosis in children. And in fact, he coins the word orthopedics. Ortho literally meaning straighten, and pedics means children. So the art of straightening children through bracing. That was the origin of the word orthopedics, interestingly enough. And this is his textbook. And fast forward another 200 or 300 years, and we reach the early 1900s when Russell A. Hibbs, the surgeon-in-chief in the New York Orthopedic Hospital, describes a new operation, which he coins spinal fusion. And the basis behind this operation is that he's intentionally fracturing the spine with the hope that the human body thinks that there's a fracture that it needs to heal, and it lays down new bone. So he describes disrupting the mechanical structure of the spine in order for the body to lay down new bone. Fred Albee further kind of develops this idea that maybe you can augment this operation by transporting the tibia, which is the bone in your leg, into your spine, and that can further help augment this fusion process. So the end result is that, in theory, the entire spine will be fused along the areas that you have disrupted it or transported bone to. Now, here's a video I would like to show you. So imagine the year is 1936. You have a back problem that's really bothering you. You go to your local physician, and this is the operation they describe. And I really want you to enjoy this. So this is the x-ray of the back from the year. They put you under anesthesia using ether. They make a cut or split in your skin. And at that point, they open up the muscles and the areas beneath the muscles, and they split that open using mechanical tools of the time. And then once they have done that, they use a chisel basically to fracture areas of your spine to create the fusion process. They take a length using a mechanical stick. They take the stick and they go down towards your leg. They split your leg open and take a piece of the tibia bone that they cut through a mechanical saw. Then they transport this cut piece back to your spine. They put it back into the spinal area. And now they put it all together using stitches, usually made of catgut. And this was the spinal fusion operation in 1936. And believe it or not, this is an operation we still use today to address a variety of spinal issues. And I'll kind of talk about where we go into the future. So fast forward another century, and now we have the modern patient. The modern patient is very educated. They have access to Dr. Google. They have access to all the technology in the world, and they frequently know a lot about their health, and they can ask intelligent questions. So frequently I see patients like this, and the first question they ask is, doctor, I've been having a lot of back issues. Do you think you can fix my spine using lasers? Well, I'm usually saddened to inform them that lasers have been tried in the past, but never really worked out for the spine, don't really help treat the issue. So unfortunately, we don't do that anymore. And usually my advice to patients is first-line treatment is a combination of rest, anti-inflammatory medicines, muscle relaxants, combination of steroids, physical therapy, chiropractic treatment, acupuncture, aquatherapy, basically a lot of things that you would think are common sense or you would think are home remedies. We start with those, and then we progressively progress toward medicines. And then if the medicines don't work, then we progress towards second line of treatment, which are steroid injections. The idea behind the steroid injections is if you deliver them in the appropriate area. So for example, in this situation, there's a disc herniation right here between the L4 and the L5 bone. And the idea is that if we deliver steroids there, in theory, the body will help reduce the inflammation, as well as the body will try to resorb much of the disc on its own. But in some cases, that doesn't work. And if that doesn't work, then we move on to surgery. And the goal of surgery is to really address very specific problems. The aim of the surgery is not to treat back pain. That's a side effect. The aim of spinal surgery generally is to decompress the nerves. That means remove the pressure on the nerves, or to fuse the spine. In other words, stabilize the spine. And there are very specific reasons we do that. And our hope is by doing those things, we can help remove the generators of the pain and therefore reduce back pain. However, just because someone has back pain doesn't mean we're going to recommend surgery. It's usually that first and second line of treatment that we recommend. And then once those fail, then yes, surgery can be an option depending on the exact pathology. So the real question though is, what does the future hold? It sounds really interesting that we are doing the same operation that we were doing 100 years ago, but how do we move forward from that? Today, I would like to kind of describe some of these areas. One specific area is use of robotics in spine surgery. And I think robotics is very interesting because it has really gained widespread adoption in a lot of areas in our society, including in manufacturing, as well as in space care, et cetera, et cetera. And public's perception of the robot varies somewhere between a cuddly bear, who is going to be the great helper and great caretaker, to the Terminator, who's going to cause havoc and somehow take over our society and cause a lot of harm. And really, I don't think either of these situations are really real or necessarily the future. But I think we can somehow adapt advantages of robotics and apply them to our situation in healthcare and try to take advantage of these things to create benefit for our patient. The specific advantages robots have: first of all, they're accurate. They try to hit the intended target. They are very precise. That means they have reliability, so they have good repeatability. And finally, they tend to be untiring, so they don't suffer from a lot of problems that surgeons may potentially suffer from, such as fatigue, long hours, etc. So the combination of accuracy, precision, and untiring qualities really makes robotics a very advantageous potential direction to move toward. And in fact, that has exactly what has happened. In situations and fields such as urology, obstetrics and gynecology, and colorectal surgery, robotics has become rather commonplace, and the Da Vinci robot is frequently used to perform a variety of very complex surgeries in these areas. And robotics allows for better visualization, so you can see things that you may not be able to see with the naked eye because of magnification that's built into the robotic camera. It can allow for improved dexterity. You only have two hands, but the robot arm can have multiple hands, multiple hooks and gadgets attached to it. So it can really allow you to hold tissues and manipulate planes in ways that are unprecedented. And finally, it has fatigue avoidance. So the robot really is a unique, it has a unique ability that it's a machine, so it really doesn't tire. So it can keep doing the same thing again and again and doing it very well. But how does this apply to spine surgery? Well, in our field of spine surgery, pedicle screws are the workhorse and literally the backbone, pardon my pun, of spine. So here's an example of a patient who had this terrible looking scoliosis where their spine is bent over almost 150 degrees, almost their pelvis bone touching their ribs. And being able to correct the spine and being able to straighten it out using the combination of carpentry, as well as being able to use screws and rods to hold bones and put them in strategic areas to straighten them out. That's what we are able to do. Now, these screws that you're seeing on the picture, these are pedicle screws. So these screws that go into the bone and are essentially very powerful. But one of the side effects, as you can imagine, is that they're very close to the spinal cord. So this is the spinal cord right here. So within millimeters of the spinal cord. So as you can imagine, this is very high stakes surgery, and you have to be very accurate and very precise in terms of doing this type of work. So how do we do it? Well, there's a couple of different ways. You can use the force, and you can do this all freehand and be able to channel your inner abilities and your training and your best known methods to accomplish this. Or you can do that and take advantage of technology. And there are basically two types of technologies that are becoming available to us increasingly so that allow us to do this. The first is called navigation, and second is called robotics. Navigation is very akin to having a GPS. So the idea is that the surgeon has a GPS in which it displays the current location of the surgical tools and the expected trajectory. Now imagine you got in your car and you want to go to the grocery store and you type in the GPS where you want to go and it shows you directions. And that's kind of what navigation is. It shows us the directions of our tools, which way they're heading. Robotics is interesting. Robotics is the next step. The idea is that the surgeon plans the trajectory either preoperatively or intraoperatively, but the robot actually directs the tools in the pre-planned trajectory. So the robot actually guides you and holds a stiff region where that's your only allowed region where you can put the tools. An example of that would be akin to a Tesla self-driving car where you as the driver just have to hold on to the wheel, but the car is doing a lot of the driving. And really, we're very lucky that at Hopkins, we have the latest technologies and access to these and able to develop these as well as do research on them and use them for patient care. And in my practice, we do a lot of this, use robotic surgery for minimally invasive spine surgery. And I'll kind of show a video of that. So this is a video of a patient of mine who's lying on their side. And I'm able to plan the screws ahead of time using their preoperative CAT scan. And what you're seeing here on the right side is the robotic arm is moving in place and showing me the exact trajectory of where the screws need to go. And as you can imagine, that's a lot more accurate than trying to use my X-ray vision or some other technological benefit, because a robot is really guiding you where you need to be. But I think the question is the robot just going to end there, or is it going to develop further? And are we going to be able to do more and more things in the future with robotic type of technologies? And my thinking is the latter. I think we are going to move beyond just pedicle screw placement. And in the future, robotic devices are going to be able to do very sophisticated things. So for example, we're going to be able to use robotics to do things like discectomies or work around nerves or work in these narrow corridors where currently we rely on surgeon skill and surgeon experience. But in the future, technology will kind of help make it easier, just like the GPS made it easier to get directions, and the self-driving car makes it easier even more. Here is an example of what we are working on in our research lab. So one of the things we have developed is a robotic spinal injection apparatus. So this is a device where that's hooked up to an injector right here. And the idea is that if you're going to go get a steroid injection, this is what it would look like. The surgeon would plan the trajectory and the robot would basically execute the trajectory and place the injection in the patient's back. And it will do that with great accuracy and great precision. Here is another example of what we worked on in our lab. The idea is that, well, what if instead of the human being the doer, the human is the thinker, the human is the planner, the developer. So what if the surgeon, instead of being the actual mechanical carpenter, which is what I am right now, what if I was the engineer and the planner? What if I could kind of plan out the exact trajectory of where my tool needs to go, where my drill needs to go, and what part of the bone needs to be drilled out in order to free up the nerves, or in this particular situation, to clean out behind a total hip replacement some of the cement. This is an example of a robot doing that automatically. So we planned all of this in the robot. We programmed the robot to do it. And the robot is basically controlling this high-speed drill that has a bending end attached to it and is able to drill out and clean out in this very tight space. So pretty incredible. And I think the idea is that in the future, we're going to see more and more of this and be able to apply this to our patients. But unfortunately, nothing is free. As you can imagine, these technologies and these innovations come at a pretty hefty price tag. And in fact, the O-arm, which is an intraoperative CAT scanner, the O-arm or the AeroCT, both of them are upwards of $1 million. The two commercially available robots in the market that are approved for spine by the FDA, the Mazor and the Excelsius, are both another $1 million. So you're talking about at least $2 million setup cost just to get going. And in the future, I'm sure as more bells and whistles will be added, these technologies will be even more expensive, perhaps. But we have to kind of weigh the benefit to the patient and to patient's health against some of these costs. So we talked a little bit about robotics in spine surgery. What else does the future hold? Well, I think another area that is under great development and we're going to see a lot of in the future is use of machine learning and artificial intelligence. And the idea behind these concepts is that we're going to rely on big data and rely on analytics of big data to be able to make better decisions and be able to make better recommendations for patients. Because a lot of surgery is not about actually just doing the surgery, but about planning and making the appropriate recommendations. And that's especially true in spine. So in the era of big data, I want you to understand the difference between these three terms. So there is machine learning, artificial intelligence, and deep learning. Artificial intelligence is just a general term that describes the idea that a computer or a non-human type of intelligence can sense, reason, act, or adapt. So a non-human machine can essentially figure out something and help solve the problem based on its experience. So that's artificial intelligence. Machine learning is a subset of artificial intelligence. Machine learning is the idea that algorithms can be developed which can improve over time as they're exposed to more data. So the more input you give something, just like a kid. So you have a kid, you teach them something, and next time you correct them, and then teach them something else, and next time you correct them, and iteratively over time, the kid can learn. And in very similar manners, you can program machines to do the same thing and behave in a similar manner, and algorithms can improve over time. So the accuracy can improve, the precision can improve. And then finally, deep learning. Deep learning is a subset of that. And deep learning basically refers to the idea that you can throw a massive amount of data at the computer, and the computer can kind of figure out on its own what's important and what's not important, what the relationships are. So instead of trying to coach the computer what the relationship ought to be, you just throw the data at it and tell it. You say, okay, A is somehow related to B. You figure out how these are related, and the computer can do that. So that's called deep learning. And in the future, I think we're going to take advantage of all three of these to improve patient care. Here's a quick example of it that's already happened. So these are CAT scans of patients with different spinal issues. And basically what the computer can do, it can automatically analyze these images using preoperative CAT scan calculations and figure out certain features that are then important for the surgeon to make decisions, like where am I going to place my screw, what the orientation of my screw is going to be, what information the robot needs to direct my screw placement. Can I automatically do that, and so on. So a lot of this automatization of the analysis, I think that's part of the future. And then I think we're going to go beyond that. It's not just going to be simple things like image analysis. It's really going to be affecting your entire ecosystem, all the way from preoperative to intraoperative to postoperative, and really impacting all body parts and all types of organs. You're going to have a series of sensors that are going to be able to integrate with each other and figure out what's really going on and what the patient's true problems are and how do we go about healing them. And I think in the surgical care, this manifests as personalized risk assessment and optimization in the pre-op phase, patient-specific resuscitation and patient-specific implants in the intraoperative phase, and early detection and treatment of complications in the post-op phase. So imagine you leave the hospital after a minor or major operation, and you have a sensor or a smartwatch that can basically send data to the surgeon and tell them at any given time, based on your overall biometrics, what's going on and whether there's something to be worried about. So kind of an early detection system. So pretty amazing. And finally, I think in addition to robotics and machine learning and artificial intelligence, we're going to start seeing biological treatments. So right now, what I've described so far is treatment of back pain and a lot of back problems using a combination of either decompression operation or spinal fusion operation. Both of these operations are non-biologic in nature. What I mean by that is that we are basically disrupting normal anatomy to get down to the nerves to free up the nerves, or we are disrupting normal anatomy to fuse the spine and force it to behave in a manner by creating a fracture so the body thinks it has to heal the fracture so that it can stiffen up the body and eliminate motion. But that's not how nature intended it to be. Nature intended the body to be supple and mobile. And by doing a spinal fusion operation, which is the best treatment we have at the moment, we are basically not doing that. And one of the ways to, what if in the future we have biological treatments where we don't have to do an operation, where we can just do injections? And we are working with Dr. Shu Kao, who is one of our research scientists, and this was very lucky to get a $9 million grant from the NIH to study this. And what we are looking at is we're looking at we're asking the fundamental question, why does degeneration happen? And what can we do to reverse it? Why do disc herniations happen? Why does arthritis of the spine occur? And how can we reverse it or fix it? And here is some data, early data in mice models where we look at disc volume. And what we found is that disc volume decreases with aging. Well, everybody knows that. Okay, that's a well-known fact. But then what we found is that maybe we can do something about it. And it turns out there's a molecule called PTH, a parathyroid hormone, which is a hormone your body makes naturally. And if you inject this molecule in the body, especially in aged mice, it actually increases disc volume. Okay, well, that's pretty interesting. So maybe it can help and salvage the disc. But what about arthritis? What about bones and degeneration? Well, the experiments show that in addition to restoring disc height, it also preserves water content in the disc. And further, more importantly, it actually modifies the biology of the disc. So it actually modifies the end plates themselves and makes them more porous and or reduces their porosity. And as a result, it basically changes the biochemical composition of the disc and the bone itself. And guess what? Well, in turn, it also reduces prostaglandins, which are inflammatory molecules which cause pain. And in fact, reduces low back pain. So the early experiments are very promising and show reduction in low back pain in mice models. So is this the magic treatment for low back pain? Well, maybe. And we hope so. Is this gonna make it from the bench to the bedside in the next 2 or 3 years? I don't think so. I think all good science takes time. It takes time to validate these models in animals. It takes time to then validate them in large animal models, then do some early human data, and then finally go for an FDA approval. The whole process takes somewhere between 50 to 20 years. And we're just at the incipiency of it. So, but hopefully in our lifetime, we'll see some of these really incredible progresses that will help convert the problem and turn it around. And instead of doing big surgeries and figuring out ways to do big surgery, we're going to be able to treat the problem at its core. So in summary, the future is bright. Robotics in spine surgery is here to stay, and it's going to continue to improve what we do as surgeons currently. It's going to help improve our carpentry. It's going to help improve the accuracy of what we do. It's going to help lead to better patient outcomes. Machine learning and artificial intelligence are going to change the game, because instead of just being tools to analyze things after they've already happened, they're going to be ways for us to predict what's going to happen and therefore make better recommendations for our patients and be able to figure out who's going to do relevant surgery and who's not. And then finally, biologic treatments, which we'll start seeing more and more of in the next 2 decades, are really going to change the game, because we're going to treat the problem at its core as opposed to trying to do surgery to solve a biologic problem. I would like to thank my co-investigators. One of the beauties of Hopkins is you get to work with really amazing people. And these are my partners from the Johns Hopkins Lab for Computational Sensing and Robotics in the Widening School of Engineering. So as a surgeon, while I'm spending most of my time operating and seeing patients, these are the people who are working hard in the lab to enable and make happen some of the things I showed about robotics. And then similarly, I would also like to thank my colleagues at the Center for Musculoskeletal Research in the Department of Orthopedics. We're very lucky. We have a really incredible basic science team led by Tom Clemens, May Van, and especially Dr. Shu Kao, who are visionaries in the field and are really coming up with incredible discoveries that are hopefully going to change the game and really help improve care for our patients. And finally, I'd like to thank my partners. And we really have a great spine surgery team, and our philosophy is to try to maximize non-operative care and try to do the best we can to prevent patients from getting to surgery. But if patients need surgery, we do some of the most sophisticated operations in the world, as well as some of the simplest. So we cover the whole gamut, and happy to take care of any of you who have questions. This is my office number. It's my assistant, Danielle, is the one who sits at that number, 443-287-0198. So happy to see you as a patient, or if you have any family members. And here's my email address. If you have any questions, happy to answer that as well. I'll stop there, and hopefully there are some questions in the Q&A.
Well, thank you so much. That was amazing and super generous of you to offer all that personal information for people. I think that'll be very appreciated. And I have no doubt that you will see some emails from the people on this webinar. But I do have a lot of questions because you gave us a lot of great information. So I'll start with the first one. Is surgery advisable for someone near age 70, lifelong scoliosis, and 62-degree lumbar Cobb angle?
Yeah, that's a great question. So scoliosis is one of the several sources of pain. And the question is really, what are we hoping to accomplish with surgery? Is it relief of pain? Is it improvement in quality of life? Is it improvement in function? And I think in order to make a decision for surgery, I recommend you come see us in the office so we can have that discussion and really look at your imaging and figure out what are the goals and what are we trying to accomplish? And the more we can accomplish, the more likely recommended the surgery becomes. However, not for everyone. A 70-year-old person is not the same physiologic state as a 30-year-old person. So as we get older, we all becomes harder to recover from surgery. So a lot of times, my patients who tend to be older, unless it's a smaller problem like a 1 or 2 level issue where it's a focal issue, we tend to talk people out of surgery. But not everybody. We have done surgery on patients as old as in their 80s and as young as babies. So it really depends, and it has to be individualized.
Impressive. I just want to remind everyone, if you have a question, please put it in the Zoom Q&A and not the chat. Some questions get lost in the chat. So throw your question in the Zoom Q&A. It's located at the bottom of your screen. So I have another question. Can you explain to us what spinal stenosis is and what you normally do to treat spinal stenosis, which of course would be on a case-by-case basis, I imagine?
Absolutely. Spinal stenosis refers to narrowing of the nerves. So it's some combination of events, whether the events are disc herniation, disc degeneration, whether it's arthritis, whether it's what's called spondylolisthesis, which means instability of the spine, or whether it's scoliosis. Regardless of the cause, it's some combination of events that essentially result in the nerves to get narrowed or pinched off. Now, patients can feel this in a variety of manners. You can feel this in terms of claudication. That means you get cramping in your legs when you walk. You can feel this in terms of shooting leg pain, like sciatica. You can also feel this in terms of numbness and tingling. All of these are various signs or symptoms that the body is demonstrating that you might have spinal stenosis. The ultimate way to diagnose it, however, is to get an MRI of the low back. And the question about treatment really varies, right? So if you have mild or moderate stenosis, we frequently recommend starting with physical therapy, trying some cortisone injections, doing some activity modification, various stretching regimens. If you have severe stenosis, then surgery can be an option, and I recommend you come see us, and happy to discuss the options there.
Well, thanks. I'm going to pass that along to my father, who actually has spinal stenosis, and may come to see you. I will certainly recommend you. So our next question is, what are the outcomes of care data post-op with these new procedures? Like, which one has the best results in terms of pain reduction and mobility?
Yeah, that's a great question. In general, the studies basically show about an 80% improvement in the quality of life with spinal surgery. Now, spinal surgery gets a bad reputation because our competition is total joint replacement, which has a 98% improvement in quality of life. So in orthopedics, when you do an operation like a total hip replacement, you have the happiest patients in the world because you're miserable your whole life. You go to the hospital, you get an operation, you walk out the same day or the next day, super happy, perfect results. And that's our benchmark. So when you compete against something that does so well, 85% doesn't seem as good. But the reality is about 80 to 85% improvement in quality of life as measured on standardized metrics over 6 months after surgery, whether it's a decompression operation or a fusion operation. Now, having said that, there are reasons why someone might do well or poorly. A lot of that has to do with individualized factors like patient's general health, what disease was being addressed, whether it was addressed appropriately, whether it was addressed sufficiently, and so on and so forth. And there's a lot of individualization in this field, and that's why it's so interesting. We have 2 hips and 2 knees, but there are more than 50 joints in your spine. So it's really pretty incredible. The amount of complexity is mind-boggling.
Yeah, it sounds like it. I never realized that. I mean, I have a mom who's had a knee replacement of a knee replacement. So it's, I'm familiar, but it's just amazing what you can do. So can you sort of briefly kind of give us an overview of fusion surgery and how that works?
Yeah, absolutely. So the classic fusion operation, as I mentioned, was invented in the early 1900s. And the idea was to disrupt the natural biology of the spine to trick the body into thinking it was fractured. So it would lay down more callus and basically heal the bones together. So it would basically get rid of the intervertebral motion. So there'd be no motion between the two bones. The modern version of it is not far from the original description. However, we have come a long way in terms of improving safety and in terms of improving patients' outcomes. So the idea now is that instead of just fusing everything, we very selectively fuse areas that need to be fused, which are areas that have instability or areas that have overall lack of mechanical integrity. So the body we need to create an environment where we join them together. And usually we do that in the setting of spinal stenosis, where somebody has incredible amount of pressure on their nerves. We want to free up the nerves. And in the process of freeing up the nerve, we are essentially also addressing the instability that's the causative reason why they have the pressure on the nerves.
Thank you. This is a good question. Are you seeking candidates for your studies?
Yeah, we have a lot of really great ongoing trials that are being run both through the Department of Orthopedics as well as through our spine center, including on back pain and different surgical treatments, et cetera. And there's a Hopkins website that lists all the different research protocols. So if you qualify for any of the studies, happy to talk to you about that.
Wonderful. Well, this is a really good question. How did you decide to specialize in orthopedics and specifically spine surgery? And is your background in engineering?
Yes, I started off as an engineer at UC Berkeley. I loved putting things together and deconstructing them and reconstructing them. So I thought engineering was a good fit for the way I think about things. And once I came across orthopedics, I realized that this is the ultimate engineering. We're really reconstructing and re-engineering the human body. Within orthopedics, I liked everything. I honestly liked every aspect of it. But spine to me really stood out because of the complexity, because of a lot of unanswered questions and the opportunity to make improvement. I think there's a lot of research areas. There's a lot of opportunity to really move the needle. And that's what attracted me about spine. And I've been very fortunate to work with great partners and great colleagues at Hopkins and really take advantage of the Hopkins strength in terms of basic sciences and engineering to kind of push our field forward.
Yeah, it looks like you've got a lot of really great colleagues, and especially in the computer sciences lab or the computational science studies lab. That's a marvelous group. Russ Taylor's amazing, and that whole crew. It's really fascinating how engineering and science and medicine all come together to help people. So, right. Given the human input in the planning process, what types or levels of safeguards are in place to program the robots that perform the surgery?
Yeah, I think that's a great question. It's something that's an unanswered question. Currently the robots are an assist device. That means just like the Tesla car, the car might drive you one way or another, but you got to hold on to the steering wheel and be able to have control and be able to steer it appropriately. In the future, the question is the human a better controller than the machine? And the answer is we don't know. My thinking is that for routine things, it's probably doesn't make a difference. But I think for sophisticated and complex things, the human is probably a better judge. So I don't think as surgeons, we tend to be control people. So we're probably not going to give up control of our tools and what we do, just because it's great to have great tools and use them to augment what we do, but it's hard to give that up.
Yeah, and you also don't want to be out of a job.
Yes. Selfish reason there. Yeah.
Yes. No. Wonderful. Well, all surgeons, I think, are artists in a lot of ways. Now, what's the future of biologics in terms of treating scoliosis?
So I think biologics for scoliosis is a very interesting area of research because we don't really fully understand what causes scoliosis. And just to be clear, there are two different types. There is pediatric or adolescent scoliosis, where you develop it right before puberty and right before menarche, right before, for young women, right before they hit their growth spurt, and young men same. And then there is adult scoliosis, which usually happens because of degeneration. It happens because of discs wearing out over your lifetime. And there are two different kind of diseases that we bundle together. I think for the pediatric kind, it usually does not cause a lot of back pain, interestingly enough, because you develop it as a kid. The reasons to do surgery are different in those patients. The reasons to do surgery in them is that you want to prevent progression of the curvature so it doesn't affect your organs as you grow older. In adults, it usually is very painful. And it's a disc-mediated process. So it's disc degeneration that's causing it. So, the biologic treatments, I think, are really going to focus on preserving the disc health and preserving how the discs interact with the bones and therefore lead to or prevent arthritis. And I think some of the PTH work is very promising in that. So stay tuned. That's the answer.
That's exciting. Do you recommend rehab before surgery and physical therapy after surgery, especially if it's invasive? And my guess is yes.
Absolutely. Yeah. I'm a big proponent of prehab, which means rehabilitation prior to surgery, as well as post-hab, that means rehabilitation after surgery. I think the human body is incredible, and our job as surgeons are to help it recover to its full potential. But in order to do that, I think the therapists and other people are really, really doing the hard work and working with patients and trying to make it happen. So absolutely.
Yeah, those physical therapists are pretty amazing. Is there such a thing as disc replacement surgery?
The answer is yes. So there are two types of disc replacements, ones that focus on your neck and ones that focus on your lower back. The disc replacements in the neck are actually a fairly nice operation, and I do a fair number of them because my focus is on minimally invasive spine surgery. And in my mind, that's a less invasive than fusing the spine in the neck. I think it's a good operation for the right patient being generally a younger patient, someone who's an active person, someone without any arthritis in their neck, and being a focal disc herniation being the problem. In the lumbar spine, the results are really mixed. They've tried it extensively in Australia and New Zealand and some of the Asian countries. In the US, the FDA has been not really on par in terms of approving all the devices, as well as most of the insurance companies don't pay for them because of the mixed results. So for the lumbar spine, it's really very controversial, and we at Hopkins do not recommend it for the most part.
That's good to know. So with respect to severe childhood scoliosis, what is the primary surgical method to correct it?
Yeah, so there are, historically there was one method. Now recently, the FDA approved the second method last year, actually. So it's actually fresh off the press. But historically, the method was putting screws and rods in the spine to stabilize the spine by fusing that segment. Now, luckily, most pediatric scoliosis affects the thoracic spine. So that's the part that's attached to your rib cage. And that part usually does not have enough mobility in the first place anyways, right? So it's not like you bend from your thoracic area because it protects all the organs. So it's pretty stiff to begin with. So doing a scoliosis operation really does not affect things a lot in terms of losing motion. In fact, really good studies show that it's minimal impact on motion and flexibility. But on the other hand, the idea is that, well, maybe if you can avoid fusion altogether, won't it be nice? And a newer technology that FDA approved last year called vertebral body tethering aims to do that. It's still in its early phases. The clinical success rate of that is about 52%, which is not perfect, but not terrible. And I think there's some room for improvement. So I guess we'll see what the future holds with that technology.
Given that outcome of 52% success, is insurance paying for that?
Case-by-case basis.
Got it. Okay, just curious. So I know I'm jumping around a lot, but these are great questions and I'm just taking them as they come in. Oh. Would a condition like Parkinson's or Parkinsonian syndrome make surgery inadvisable, by complicating recovery? So I guess if you had those conditions, would you not want to do surgery?
I think as surgeons, one of the great privileges we have is we have the privilege of not only operating on people, but really counseling them. And I take that job very seriously. I think I spend most of my clinics talking people out of surgery, and it's for a variety of reasons. And one of the reasons might be, depending on your physiologic state, if you have really severe conditions like Parkinson's that are very advanced. If it's a well-controlled, well-managed Parkinson's, you have a small spinal problem that can be addressed fairly straightforward with minimally invasive options, then yeah, surgery is a great option. But if you have very advanced Parkinson's that's not controlled and really, poor musculature and atrophy and frailty, and you have a major thoracolumbar scoliosis, I don't think surgery is a great idea. I think that, that's a recipe for setting you for failure. So we take our job very seriously and make the best recommendation as I would for a family member.
That's wonderful. Thank you for taking that care of people. Is there a surgery for widening the narrowed spinal column due to stenosis? Absolutely. Yeah. So there's lots of different ways we can do that. The analogy I use with my patients is that you're born with a 5-lane highway, but due to some construction on the road, now you're left with a 2-lane highway. And my job is to kind of fix the construction so we can get you back to the 5 lanes, because and that way all the signal and all the traffic can flow. So the answer is yes, and there's lots of different kind of surgical nuances that we can apply. The bottom line is it's called a decompression operation, and we can do it minimally invasively using microscopes and such. So similar to the question about Parkinson's syndrome, like if somebody has arthritis, does that make a difference for how you treat them? And do pre-surgery options vary with respect to whether or not somebody has arthritis?
No, arthritis is actually one of the most common reasons why someone might get surgery. Because what arthritis does is it creates spinal stenosis. That's the construction on the side of the road. That's what's narrowing the highway. So our job is to be the cleanup crew and get rid of it. Good.
Thank you. So you had talked about the 1936 surgery for spinal fusion involving a chisel to fracture the bone. What are some 2021 versions of the chisel that we use to trick the body into fusing vertebrae?
Yeah, great question. We have very sophisticated tools now. So instead of literally damaging the bones, we can kind of abrade them. So we have microscopic or ultrasound-based tools that run at high frequency, and they can use to kind of open up the bones. We have high-speed drills that rotate at 70,000 RPMs that are used to do the same. And so the point is we have really moved forward leaps and bounds to really advance the technology quite a bit. It's kind of akin to a 1936 vehicle, a Ford Model T versus your modern Tesla, right? It's also a Model T, but it's a different car. It's like being in a rocket ship. Yeah, I can imagine. I mean, even the medical devices out there every day, with our wonderful friends in engineering, it's making everything better. Now, can fusion surgery be revisited if tingling, numbness, and weakness continue? Yeah, absolutely. I think the first line of treatment is always, physical therapy, non-operative treatment, home remedies, activity modification, etc. And if your issues progress despite of that, then second line treatment being injections. And then if your issues persist despite of that, then yeah, surgery is an option. But the point is, you don't have to jump to surgery. In most cases, we don't. We tell people not to. Yeah, I like that, because that's a lot for somebody to go through. So I like your conservative approach and safe approach. Now, does Hopkins do platelet-rich plasma injections in the spine? We do PRP, platelet-rich plasma injections. For spine, the data is very mixed. Most of the studies show that it hasn't panned out yet, so insurance companies don't pay for them. But having said that, we have some providers who do them and do a great job, and happy to connect you with one. And it looks like we have one more. You guys have done a great job asking questions. These are amazing questions. And this is kudos to you, Dr. Jain, because I don't know that I've ever seen this many questions in a webinar. So you're really engaging and people obviously are really into it. So what do you think about kyphoplasty treatment? Yeah, kyphoplasty refers to injection of cement in the bone to beef up the bone. It was all the rage about 15 years ago. Lots of people were doing them and they thought it was a great idea, especially if you have weak bones and osteoporosis to kind of help beef them up, or if you have a fracture in the spine. It's still a good treatment, but I think it's for very specific indications. They did a very large randomized controlled trial that was published in the New England Journal, which basically showed that it was no better than sham surgery. So insurance companies stopped paying for them for the most part. But having said that, for very specific indications, such as an acute osteoporotic fracture. So if someone has osteoporosis and has an acute fracture, so it just happened, or for someone who has very specific types of pain because of osteoporosis that they have an impending fracture and such. I think for those situations, it can be an excellent pain relief treatment. But I think for spinal stenosis and other conditions that we generally treat, it's not recommended.
Well, that's great. Well, I mean, I can't thank you enough. This has been an absolutely wonderful webinar. You're a delight and super engaging. And I know if I ever have a problem, I know where I'm going, and I know to whom I'll send patients, including my dad, who I think would really benefit from a consultation. So I appreciate you for your time and talent with us today. A follow-up email will be shared with everyone who registered for this amazing program, and it'll include a recording of this program along with a list of resources and our event schedule. And we hope you will join us at a later webinar. So, with that, stay safe, stay healthy, stay cool, because it's really hot out here. And I don't know if your neighborhood is infested with cicadas, but mine is. So maybe stay inside.
Have a great day, everybody. Thank you.
Thank you. Have a good one.